On everything's up yesterday.
All right. I think people are starting to join. We got one person. It might be you, though. Hello, TikTokers, YouTubers, Facebookers, Xers, and
Instagram.
Instagrammers. Yeah, all right, good. Hello, everybody. I am your host for tonight's show of Dr. Rahi Victory and Tarek Ibrahim doing fertility factor fiction. I am Dr. Victory, of course, hence the green scrubs, which I did not have time to change out of. So you got me in the medical raw, so to speak, I guess.
I like it.
Yeah. Today was a busy day. I have a fabulous fellow in reproductive endocrinology visiting from the London program. And he's amazing. I love the guy. He's great. So if you're watching, kudos to you. You're going to be awesome. I may try and steal you and keep you for ourselves. You like him. He's from Saudi.
Okay.
Yeah,
He was
he's a
mentioning him.
really good guy. Super nice. I love the guy. He's great. He's really smart too. So treats people very much like I do. So I like that.
The common thing already has begun on TikTok.
Yeah. Right.
Soraya is here.
Soraya is here. Hi, Soraya. Welcome back. So yeah, tonight we're going to be reviewing something really cool with some controversial stuff, hopefully. So I hope lots of people are tuned in. So as part of my license for the US board, they send us a whole bunch of articles we have to read, and most of them, thank God, knock wood, I've always read ahead of time, but some of them I haven't. And so we have to be able to go through those articles and then answer questions, and you have to score over, I think it's 90% or 95% or something like that, in order to not have to redo your American board exam. God forbid, I would hate to have to redo that exam. It was horrible. So I've happily maintained a almost 100% average. This year I got 100% again for several years now. So I have managed to skate by without having to redo my exam. And this year an article came up which I had not seen because it was from the Society of for Maternal Fetal Medicine. So there are different subspecialties of OBGYN. So on the OB side, we have maternal fetal medicine. So basically the obstetricians that deal with high risk obstetrics, which in our community, I kind of have become not the high risk specialist, of course, because I'm not trained for that, but I get a lot of high risk patients. So I do a lot of that stuff here. And then there's urogynecology for women with leaky bladders or pelvic prolapse. There is gynecologic oncology, which is when you're a cancer specialist. There is REI, so we do the reproductive endocrinology and fertility. And then now there's also this other specialty of MIGS, which is gynecologic minimally invasive surgery. And then finally, there's adolescent and pediatric gynecology as well. And each of these have their own dedicated training programs. In the US, they all have board exams, and so they're dedicated kind of fields where you have to find stuff. Soraya is showing a sheep. I have no idea what that is. So in terms of these guidelines, they are from the Society for Maternal Fetal Medicine, and the Society for Maternal Fetal Medicine is not something I routinely read because it's high risk obstetrics. So they actually had guidelines for the management of pregnancies resulting from in vitro fertilization. And I thought, you know what, this is a great opportunity to share stuff with our viewers because many of you are getting pregnant as a result of listening. And so now we need to help you graduate through the next stage and kind of figure out how to manage that next stage, which is the pregnancy. So this doesn't deal with psychological and emotional stuff. I will say very clearly that someone very near and dear to me, Dr. Julia Sen, she's a fantastic PhD in fertility psychology, told me once something I'd never even thought of, which is that women who are successful or couples who are successful and manage to conceive, regardless of what method they use, still carry a lot of trauma from their experience into the pregnancies. So there is no question that there is some psychological, stuff, concerns that people have as they manage their way through their pregnancy. And we're not going to be talking about that tonight. not because it's not important. I fully recognize that it's actually quite critical and that should be dealt with, but that's just not part of the Society for Maternal Fetal Medicine guidelines. But if you are wondering about that, connect with Dr. Sen or our psychologist or social worker. We have lots of people here who are amazing who can help you, and Dr. Sen is on top of that as well. Okay, so jumping right into it, can we share? Am I already sharing?
You're not really sharing.
I'm not already sharing. I thought I was sharing. No, I am already sharing.
Oh, yeah, you think you're sharing.
Do I need to
just want,
reshare?
no, you're good, you're good.
Okay.
I'm just not sharing. But we can share now.
Can we please share?
We're sharing.
We're sharing. Okay, so these are the guidelines. And so this is a obviously very clear, manuscript written where they looked at a committee sat down and evaluated the data and checked everything out. So we're going to talk about the different things in here. So I kind of highlighted the important parts and the big topics because I'm not going to drive everybody crazy and spend 3 hours on this. We could quite easily, but there are a lot of numbers to go through, and it's important you guys know about this stuff because it really supports a lot of the stuff we've been doing for ages, and they're now supporting through the data, and we were doing it all before. And it also supports some other things that you need to think about and probably knew already. And then the last little bit, I'm going to actually disagree with them, but we'll get to that in a minute. So it says, what genetic condition should be discussed with patients considering to undergo or who have undergone IVF? So they say very clearly that there's no question that there is a higher risk of genetic abnormalities in infertility patients, whether it's coming from the male or the female. There are several conditions that can lead to this. In fact, there's a very recent study which showed that even patients with endometriosis actually have a higher risk of genetically abnormal embryos. So it's super important for you to at least have a discussion of genetics when you're considering doing IVF. So they talk about things like several other factors may play a role in increased risk for chromosomal abnormalities, including age and even polycystic ovarian syndrome. Severe male factor and female factor infertility has higher risks of chromosome abnormalities. There's a 1.5% rate of karyotype abnormalities, chromosomal abnormalities, reported in couples referred for IVF. So automatically, if you're referred for IVF, there's a 1.5% chance you might have a genetic abnormality. 1.8% for men, 1.2% for women. The need for genetic screening is well established for several infertile subpopulations, including severe sperm abnormalities, women presenting with primary amenorrhea, where you've never had a period before, premature menopause, so diminished ovarian reserve cases, which are really early, and those with recurrent pregnancy loss. So all of these things can lead to us needing to check it out. In guys who have azoospermia, approximately 10% of the men diagnosed with oligo or azoospermia will have a genetic abnormality, or what's called a microdeletion in the Y chromosome, where a very small gene, it's called the SRY gene, may be missing a portion of itself. And if that's missing, you can either have very, very low sperm or no sperm at all. So their summary here is that we suggest that genetic counseling be offered to all patients undergoing or who have undergone IVF with or without ICSI. And so I'm really proud to announce that effective kind of immediately, we have now included genetic counseling for all of our IVF cycles for patients that want it with this awesome group out of Toronto called Genomacare. We're not increasing our prices. We're absorbing that cost because we feel strongly that patients should get genetic counseling to help guide them through their decision-making process and to help guide us on who should we do additional testing on, who should we not do additional testing on, should you do PGT, is it going to be beneficial for you, how is it going to be beneficial for you, and so on. So some really great information there, and they are saying that they recommend that it be offered. We're actually including it for free. You're certainly welcome to turn it down, but we're actually including it, which to the best of my knowledge, nobody else is offering right now. So we're really proud of that. The next one's what are the different types of pre-implantation genetic testing? I'm not going to go through that other than to say there's 3 types. You can check for PGT-A, which is the general testing where we just look for karyotype abnormalities. How many chromosomes are they balanced and so on. There's PGT-SR where you know you have a genetic abnormality like a translocation or a inversion or a deletion, and we're looking for small little chromosomal rearrangements. And then there's PGTM where you have, for example, cystic fibrosis, and we're checking you and your partner, and then if you both have it, we got to make sure the embryos don't have it, or at least try and screen them for it. The new thing on the horizon, which we've implemented, is genetic testing via artificial intelligence, where they believe that they can tell from just looking at images of the embryo whether the embryos are normal or not. So I have to say, it doesn't have quite the prediction value I'd like on an individual embryo basis. So if you're looking at it in terms of embryo by embryo, it's about 76% predictive of a normal embryo if you get this really high embryo score, which is reasonable but not ideal. But if you have two embryos with that same really high score, it's got a 97% chance that at least one is genetically normal. And that's actually quite robust. I mean, those are numbers we'd be very happy with. So I learned that recently in Scotland. That's very valuable information. So we're really pleased to hear about that and know that that's a significant finding. Okay, again, they say regardless of whether PGT has been performed, we recommend that all patients who have achieved pregnancy with IVF be offered the options of prenatal genetic screening and diagnostic testing via chorionic villus sampling or amniocentesis. So I'm going to take a little bit of issue with this. When you do a CVS or an amnio, you're biopsying either the placenta in the case of CVS or taking fluid out of the uterus in the case of amnio. You can do CVS around 11, 12 weeks without much risk of injury to the baby. You can do amnio typically around 15 weeks. The problem is both of these carry a not insubstantial miscarriage risk. So it's 0.5% with amnio and it's 1% with the CVS. Sure, it's low, but it's substantial. And in this day and age where we have enhanced first trimester screening, we have non-invasive prenatal testing, I'm going to argue that this is erroneous. We do offer it to everybody, but no one's taking us up on amnio or CVS. It would be absurd after working so hard to achieve a pregnancy and then go and do an amnio or a CVS. Certainly if there looks like there's concerns, like there might be a baby with Downs, or there might be a baby with a chromosomal abnormality, or you see malformations and you want to make sure the baby is genetically normal, totally different story, right? You should be entitled to check. And in those situations we do. But in routine situations, no REI is recommending the patients go and do CVS or amnio. And if they are, I think they're crazy. Okay, what is the accuracy of first trimester screening? So this is really cool because we do enhanced first trimester screening tests. So I want to read this to you. The accuracy of first trimester genetic screening tests for aneuploidies may be affected by IVF. In a recent systematic review, when compared with naturally occurring pregnancies, pregnancies achieved with IVF were associated with decreased pregnancy-associated plasma protein A, or PAP-A for short, and increased nuchal translucency, which is the measure we use to detect if the babies are genetically normal or not for Down syndrome. In terms of other things, they have decreased alpha-fetoprotein and transcription factor, increased estriol, and increased total HCG in the second trimester. So all of these are things we look for when we're doing the enhanced first trimester screen, and they're not quite where they should be in normal pregnancies. Another meta-analysis confirmed significantly lower PAP-A levels in any IVF, even if it's with or without ICSI, compared with controls. So that's really significant. But they didn't find a difference in the NT measurements. So all of this is important. Even if you're doing the NIPT, where we actually find the baby's blood cells in your maternal blood, there is a lower fraction of the fetal DNA in maternal circulation when you've had IVF, meaning there's a smaller placental mass. So essentially they say we recommend that the accuracy of first trimester screening tests, including the NIPT for aneuploidy, be discussed with patients. So if you're doing IVF, if you've achieved a pregnancy, when we're offering you the enhanced first trimester screening, we do need to tell you that it's not quite as accurate as it would be in someone who's not doing IVF. Now, thankfully in Ontario, we have to label whether the pregnancies are IVF, and they factor that into their calculations. So we are quite careful about that, but important for you to know, it is not as accurate. So if you get an NT score, which is not quite where you want it to be, and you're panicking, don't panic, because in an IVF pregnancy, the NT is allowed to be a little bit thicker, so don't panic about that. They're talking about multifetal gestation reduction. Don't worry about that. We don't have that happen anymore in IVF. So that's not a problem because we refuse to put in more than 1 or 2 embryos. Okay, are congenital abnormalities increased in IVF pregnancies? Is your baby going to be at a higher risk of being abnormal? And the answer is yes. There are associations between IVF. So I'm going to expand this because they do say you need a detailed ultrasound. So I want to show you this. First of all, here, let me say it down here. They do see a higher rate of congenital heart conditions in babies with IVF. So they now are suggesting that fetal echocardiography be offered to patients with pregnancies achieved by IVF, something we have not done to date, and we are going to now pick up. It's not high-level evidence, it's grade 2C, but you can't have a guideline like this and not offer a fetal echo to patients. So we are going to be doing detailed ultrasounds of babies' hearts now if patients want us to. Certainly, if the initial one says there's nothing wrong, you probably don't need to panic, but it's reasonable to offer this to patients based on this data. What other abnormalities are increased? So cleft lip or palate, not increased because the confidence interval crosses 1. Eye, ear, face, neck, not increased. CNS, which is central nervous system abnormalities, it is increased, but it's not actually increased compared to natural pregnancies. So it's 1.7 versus 1.7. So there's not a huge rate change there. GI abnormalities, 3.8 versus 2.5, that is increased. And it is statistically significant. Musculoskeletal, huge increase, 11-fold. Urogenital, so kidneys, bladder, things like that. Again, huge increase, almost 11-fold, and much higher than it is in the regular population, almost double. And cardiovascular, slightly above the regular in the population, but highly significant. So it's 5.7. So that's quite a high number in terms of the risk rate. This is per 1,000. So all of these are decimals or 10.9 or whatever per 1,000 pregnancies. So these are important for us to consider as well. You do need a very detailed ultrasound. You cannot have just anyone doing ultrasounds for these pregnancies. What about placental abnormalities? Every type of placental abnormality is increased. Placenta previa, placenta accreta, invasive placentas that have the cord inserting funny, vasoprevia, they're all increased. So you do need to be more cautious when you have an IVF pregnancy with the placenta. And they say we recommend a careful examination of the placenta, placental shape, and the cord insertion site be performed at the time of the detailed fetal anatomy ultrasound so that you can evaluate carefully. And this is grade 1B evidence. Now, I don't know of any ultrasound place that doesn't do that, but it's critical that we be very careful with it here. Okay, so what about preterm birth? Is preterm birth higher in pregnancies achieved with IVF? Yes, it is. That's why we keep our patients on progesterone. So people always say, why are your patients on progesterone for so long? It's because I've known for ages that the preterm birth rate is higher. So preterm, it says risk for preterm birth is higher in all types of singleton gestations from ART. So any type of fertility pregnancy, you have a higher risk of being born early. They highlight that by saying, even in pregnancies associated with IVF after egg donation, they have higher risk than patients that get pregnant with their own eggs. And so all of these things are really critical. There's no question that your preterm labor rates are higher. They don't recommend serial cervical length monitoring past that 20-week kind of anatomy ultrasound time. But we do need to be very careful with these patients because they are at high risk. So some type of vigilance is important. It's critical that if you go in crampy, your doctor not ignore it and say, oh, it's fine, because you actually could be in labor, and that's really important. Is the prevalence of fetal growth restriction higher in pregnancies achieved after IVF? The answer is we suggest that an assessment of fetal growth be performed in the 3rd trimester. This is not something I knew about before. We are now going to have to do growth ultrasounds on everybody when they're in the 3rd trimester, probably at 32, 34 weeks, to make sure that the baby is growing and make sure that the baby is growing normally. So this is really critical because that's not something that's being done routinely that I'm aware of. What about aspirin? So they say here, we do not recommend low-dose aspirin for patients with pregnancies achieved with IVF as the sole indication for preeclampsia prophylaxis. However, if there's one or more risk factors present, low-dose aspirin is recommended. So I disagree with that because all IVF patients have risks for preeclampsia. And we know that it reduces preterm labor, so aspirin can be beneficial. It improves blood flow, it reduces complications, and there is a very, very, very minimal risk of bleeding from taking aspirin. So I take issue with this one. I disagree with them. I do believe aspirin should be given to all IVF patients, and we do use it for all our IVF patients. Is the prevalence of stillbirth increased? So I got asked on Instagram the other day if I think that a patient should be allowed to have a home birth. And we have lots of people who argue that they want to try and have a natural labor without an induction of labor, even in an IVF pregnancy. So I do take issue with that. Stillbirth is increased. You have a 2 to 3-fold increased risk of stillbirth if you are in an IVF pregnancy, even when you control for all the risk factors. One meta-analysis found the rate was 11.8 per 1,000, which is high, with an odds ratio of 2.6 in pregnancies achieved with IVF compared to a naturally occurring pregnancy. So this risk is huge and very, very worrisome. And it doesn't matter if you did it with frozen or fresh, although frozen embryo transfers have lower risk than fresh. So that's also important and a big part of the reason we do frozen embryo transfers. So I'm very happy to be seeing this, and I think that that's really important. So they do say, given the increased risk of stillbirth, we suggest weekly antenatal fetal surveillance beginning by 36 weeks, and we do that anyways. That's part of our Ontario protocol. And then finally, does induction of labor at 39 weeks reduce the risk of adverse effects? So here's the one where I don't agree with them on. It says at the bottom that in the absence of studies focused specifically on timing of delivery for pregnancies achieved with IVF, we recommend shared decision-making between patients and healthcare providers when considering induction of labor. They do admit that induction of labor does not increase your risk of cesarean section. That's true. They claim that based on one meta-analysis, it does not reduce your risk of perinatal outcomes. However, if you look at the ARRIVE trial, which is the best done study, looking at induction of labor for all women, not IVF patients, at 39 weeks, there is a reduction in maternal risk and fetal risk. High blood pressure, preeclampsia, admission to ICU, admission to neonatal intensive care unit as well. Reduction in cesarean section. And they've got other studies which demonstrate very clearly that satisfaction rates are the same. Check out our video on YouTube. We have a great video on induction of labor. I had to create that because I got sick of all the crazies on Instagram who kept saying you should wait till you're 48 million weeks before you have your baby. So watch that video. Now, why do I disagree with this kind of schmarmy line at the end of this? Because we already know from everything else in here, you're at higher risk. You're at higher risk for stillbirth. You're at higher risk for high blood pressure. You're at higher risk for complications. There is no justification for waiting if the risks are lower, which we know they are, with the induction of labor, and your risk of cesarean section is the same. Why would you wait? You're only increasing the risk of stillbirth. And to me, that's maniacal. It makes absolutely no sense. So hopefully, if you're with an obstetrician who knows you are an IVF pregnancy, and they are trying to take appropriate care of you, they should be talking to you about induction of labor at 39 weeks when you're carrying an IVF pregnancy. Earlier if you have multiples like twins, but if it's a singleton by 39 weeks, in that 39th week somewhere, you need to definitely plan a delivery. Yeah, KM says, but what if your OB plans a trip when you're 39 weeks and want an induction? I'm sorry, Kim. I can't help that. Yeah. Anyways, hope you enjoyed that. IVF pregnancies are different. I think that's the take-home message. It's super critical that you get great obstetrical care when you're pregnant. I don't believe that IVF pregnancies should be managed by just everybody. And I'm sure I'm going to get lots of controversy from that. But thankfully, the people that want the home births are not always watching this show. Do I think you should have a home birth in an IVF pregnancy? Absolutely not. I do not think that that's safe. Can you have a midwife? Of course you can have a midwife. I need to make sure that the midwife's interests are prioritizing your safety and your baby's safety and not prioritizing a natural delivery. Because when it comes to the whole gamut that you've run through for an IVF pregnancy, achieving the birth naturally should not be the goal. The goal should be achieving your safety and your baby's safety. And if that means we can do it naturally, hallelujah, that's the best thing ever. But if you need an induction, if you need a cesarean section, if you need antibiotics, if you need oxytocin, whatever you need, then you have to be open to the idea of taking that. And the goal should never be as natural a delivery as possible. It should always be as safe a delivery as possible. That's the primary goal. After that, all the other fluffy, wonderful stuff, great. But prior to safety, absolutely not. That's the number one thing, and it outweighs all the other ones by miles. Busy?
Yeah. I like to try to take a... Anyway.
Take a picture?
So, Dr. Victory, we'll start with the questions.
Okay.
I froze my eggs,
Yeah.
and some of the eggs matured in the lab in a petri dish 1 to 2 hours after the egg retrieval.
Okay.
Is the likelihood of those eggs becoming a baby very small because they need extra time in the lab to mature? One fertility doctor told me to pretend those eggs didn't exist, and another fertility doctor told me there is no clinically significant difference between those eggs and the eggs that were mature when they left my body during the egg retrieval. Swear to God.
I can't believe people come up with this stuff. Yeah, so actually there's a study on my phone, which is videoing me on TikTok right now, which I can't share with you, but it was just released recently, which demonstrates that eggs that are matured in the lab only have about a 10% chance of resulting in a blastocyst embryo that is going to result in a positive outcome in terms of being a baby. So saying that it's the same as a normal egg is absurd, and saying they don't exist is also absurd. So both those doctors are wrong. In vitro matured eggs don't do nearly as well as ones that are naturally mature when we get them. But there is a chance, it's just very, very low. That was me, Donner.
Okay.
I hit the foot pedal.
I was genuinely wondering how I have placed something so perfectly on the ground and it still tipped over.
No, it's my foot pedal and
Okay.
my elliptical, under the desk elliptical, yeah.
Calf day every day.
Calf day every day, yeah.
Hey, Dr. B&T. Tomorrow I have my IUI teaching.
Okay.
I'm wondering, what is the success rate for IUI with letrozole and trigger with someone with PCOS? Everything else is good, minus PCOS.
10 to 15% per try. It's easy.
There you go.
Easy.
Hi, Dr. B&T. Besides taking it early in the morning, do you have any suggestions to help insomnia for prednisone?
Oh, most people don't usually complain about that. Melatonin if you're having trouble. There's nothing else. Warm milk and bananas make you sleepy. They raise your serotonin levels. You can try that too.
Warm milk in general makes you sleepy.
Yeah.
Bananas make you sleepy too?
Yogurt, warm milk, bananas.
Really?
Yeah, apparently.
Huh.
Although I love bananas and I don't get sleepy.
I've never heard like, oh, you know what? You know what? Come to think of it, my mom always tells the boys, because they're a little bit slightly, you know, they got a little bit of their dad in them, you know what I mean? So my mom will always say, eat a banana before going to bed. And I've always just looked at her like, what's the deal?
Yeah,
But maybe there's some bedtime remedy in there.
maybe.
Yeah, because you said banana, right?
Yeah, banana.
Yeah, bananas.
Yeah,
Maybe
yeah,
it's true. Hey, Dr. V, we are wondering, what's the best way to get a hold of the clinic? To get a hold of the clinic is, we have been trying to get our blood results from October 2023. We've emailed and called, but no one seems to know on the phone, and no one has replied to our emails. Just looking for some help.
That's impossible. We answer phone calls every day and we answer emails as well. So, can you write down the name? Do you know who it is?
Yeah.
Yeah, write down the name and I'll figure it out. And I'll pass it on to whoever needs to deal with it.
Okay.
Just twist.
Do the twist.
Yeah. And you make sure you leave a message. People call sometimes and then they don't leave a message if it's not answered. So we will definitely get your answer if you leave a message. So make sure you leave a message. Yeah.
Hi, Dr. VNT. I've had several failed FETs with euploid embryos using various protocols. All my labs and tests are normal. The mystery begins.
Yeah.
I've just been diagnosed with basal cell carcinoma, treatable skin cancer.
Yeah.
How much impact, if any, would this type of cancer have on an FET success rates?
Theoretically, zero. I mean, it's going to cause some stress in you, but basal cell carcinomas do very well and you remove them and it's gone, right? Lots of people have basal cell carcinoma, so that should not be a major issue for you. I definitely want some healing time. I want your stress to go away, but that's not a major issue. I wouldn't worry about that at all. Yeah.
Below optimal sperm motility and sperm count. Baby dances every day or second day infertile window.
Oh, they're asking every day or every second day? Every day.
Natural pregnancy after failed FET. Should I still take progesterone?
That's a great question. There's no evidence that you need it, but if you've had to have IVF done and then you manage to conceive naturally, the bigger question is, what's the benefit of taking progesterone? Reduced preterm labor. What's the disadvantage of taking progesterone? Gooey vagina. So when you weigh gooey vagina versus reduced preterm labor, clearly I would err on the side of reduced preterm labor, but it's not for everybody.
What do you think of electroacupuncture?
Electroacupuncture? Never even heard of electroacupuncture. Yeah.
Can a FET be successful with no symptoms, no cramping, spotting, or discharge changes?
1,000,000% yes. You can absolutely be pregnant. Every woman's experience of pregnancy is different.
What are the percent chances of injectables in IUI, like a general percentage?
20 to 25.
You forgot your horloge today.
Oh, my watch. That horloge. Yeah, sorry.
Where are you based? They answered that for you. Windsor, thanks. Canada. Stabilized. Okay, that's vague. Can you use AI testing on already frozen embryos to look at them, or do they need to be thawed?
No, we can use AI testing on already frozen embryos because it's assessing the time-lapse embryoscopes that we have. We now have two. So that's what it's assessing. It's assessing our time-lapse embryoscopes.
Does endometriosis affect egg quality or just quantity? Is it worth investigating with a lab if you're older patient, 40 to 42, or just move ahead with egg retrieval in interest of time?
It affects egg quantity and egg quality when you have endo because it diminishes your ovarian reserve and it impacts your egg quality for sure. The time question is important, but you've got the sequence backwards. So if you think you have endo, in my opinion, the best sequence of events is to do your IVF, all your IVF first, retrieve as many eggs as you can, make as many embryos as you want, and then do the surgery, because every time you do IVF, your estrogen level is going up. Estrogen is what feeds endometriosis, and so your endo is actually getting worse. So if you operate first and then you do 3 cycles of IVF, you're going to potentially need surgery again because you just made the IVF a lot worse, or sorry, the endo a lot worse. So we don't believe in doing the surgery before the diagnosis of, or sorry, before the IVF treatment, except for very special circumstances. So typically I'll tell people to get their IVF done first, and not to do the surgery first. Your light went out.
I see that.
Do you want me to turn this little
No,
smart?
I'll get that one.
Okay.
My doctor is recommending GCSF for our next embryo transfer. 8th transfer, never had implantation. What are your thoughts? And we'll be using my parts of your endo protocol. We'll be using many parts of your endo protocol.
I would need to see you and figure out what's wrong. I mean, I don't believe in, 8 failed transfers. Something is clearly wrong. I need to know what it is. So I would need to have you talk to us if you haven't already. You must have if you're doing my endo protocol. And then I would want to know what testing you've done. And if we've done fertility testing, if we've ruled out microbiome, if we've ruled out this, that, and the other thing, then sure. Yeah, I mean, I'm all for it. But if you haven't ruled everything out, then I definitely would tell you we need to make sure we've ruled everything out first.
Sorry.
Sorry. Twist it a little more. Yeah.
Just stop it abruptly. Hi, Dr. V and T. What are the pros and cons for taking progesterone during pregnancy, and can it help reduce miscarriages?
I believe it can reduce miscarriages if you start it early enough. The data is very clear that if you start it later, it does not reduce miscarriages. It can reduce preterm labor. That data is crystal clear. With regards to other advantages, there are none. What's the disadvantage? It makes your vagina gooey. It's expensive. And there may be an association in boys with a change in the look of the genitalia, which can be significant. I've only seen it once in my entire career. It's impossible to know if that's related to progesterone or not. And I mean, we've had thousands of babies now, and it's not like all the boy babies are coming out with a problem. So I'm not sure about that part, but it has been reported before.
Is there any way to get another ultrasound before birth? 20 weeks to 40 weeks seems so long. How do I know everything is okay?
Well, in Ontario, we're not allowed to, although now with these guidelines, I'll start doing a growth scan at sometime in the 3rd trimester, probably 32 to 34 weeks or something. But from the standpoint of, can you? Sure you can. You just have to pay for it. And I'm not asking you to pay me. I'm just saying we're not allowed to bill OHIP, which is the Ontario Health Insurance Program, for an ultrasound unless it's necessary. And there isn't one that's necessary just because people are worried. So you can do one for kicks just to see. We are starting our 3D ultrasound service here. So that'll be a like you pay for it kind of service, and then you get those cute little 3D images of the baby. We have the best 3D ultrasound available, so that'll be started very, very, very soon.
How likely is it to not be ovulating even if you're having LH surges and have a very regular cycles?
Extremely unlikely that you're not ovulating if you're having LH surges and regular cycles. You would almost for sure be ovulating. It is possible not to. I forget the exact number. I think it's as high as possibly 6%, but 94% of people that have an LH surge are actually ovulating.
If you detect abnormalities after a natural cycle monitoring, do you reach out to the patients quickly?
Not unless the abnormality is life-threatening or dangerous in some way. I mean, if I see some giant worrisome malignancy or something like that, of course. But in the absence of something like that, we review it with you when you come in for your first appointment.
Should my partner and I begin taking CoQ10?
Depends on what's wrong, but there's no downside. Amanda says, hello, Dr. Victory. Nice to see you. Nice to see you too.
Hi, Dr. VNT. I did a biopsy. Results came back as irregular endometrium and secretions benign. What should be my next step? Is a biopsy sample sufficient? Additional tests recommended protocol.
I don't know what's wrong, dear, so you'd have to give me more information. What I will tell you is that endometrial biopsies are useless unless you're trying to detect endometrial hyperplasia or cancer. They're not useful for patients with infertility. So I don't know what you're looking for there. I need to know more.
Hi, Dr. VNT. Dr. V, I guess this is for you. Would you be able to comment on whether you recommend the RSV vaccine in the third trimester?
Oh, wow. We just had a guy come by today from the RSV.
Oh, that's what he was.
He's the guy.
Ah, that's
Yeah.
hilarious.
So it probably is worth taking RSV vaccine. Vaccines in pregnancy are safe, and getting RSV in a baby can land the baby in the hospital and in the NICU and intubated and very sick and even potentially at risk for bad stuff. So yes, I do think that RSV is probably beneficial. I have to admit, I have not looked at that data yet specifically. Maybe that'd be a good topic.
That's a great topic.
You know what? We could do
That's a
that
great
next week.
topic.
That's a big one.
Yeah, that is a
Should
big
you
one.
get RSV while you're pregnant?
A lot of people
Or a
are into
YouTube
that.
video?
Oh, yeah,
Let's do a
that's
YouTube
good.
video. Yeah, we'll do a YouTube video for you. I can look up the data on that.
Hi, Dr. VNT. I had LAP after high BCL6.
Yeah,
And it was negative for endo.
that's receptiva.
Oh, I love it.
There you go.
The
Useless
cycle
test.
I did.
That's why I keep telling everyone it's
The
useless.
cycle I did the biopsy on 10 DPO. I was actually very early pregnant and cyclia chemical. Do you think the elevated BCL6 was due to implantations because it's an inflammatory process?
Oh God, no idea. I do not know anything about BCL6 because it's useless, so I don't even follow it. But I guess so. It could have been that. BCL6 is useless. Don't do receptiva. It's a useless test. They know it's a useless test. Multiple studies have proven it's a useless test.
I'm still breastfeeding, but considering a consult for my next baby to start on any supplements and get on the funding wait list. When do you suggest doing this? I want to be ready to go once weaned.
If you want to get on our funding wait list, you better get on quick because we're, I think, either done or almost done for 2024. I think we only have a couple of spots left. So if you're thinking about that, get in quick. If you are wanting supplements for breastfeeding, that's easy. I would recommend you just take, or sorry, not for breastfeeding, for fertility while you're breastfeeding, just stay on your prenatal, fish oils, vitamin D, and iron for now. That's all you need at the moment.
I'm 23 days late for my period, but spotted at 19 days. Would that have been a period only when wiping?
Say that again?
I'm 23 days late for my period,
Yeah.
but spotted at 19 days. Would
Okay.
that have been a period only when wiping? I actually spotted only when
I
wiping.
have no idea. I mean, there's no way to answer. Go get a pregnancy test.
Yeah, okay, good answer.
Oh, you approved, dude.
Yeah, that's good. That's good.
We all have Tarek's approval.
Yeah,
A round of applause for me.
not bad, Dr. Ricky. Not bad. I approve of this message.
Oh, hey, can I announce?
Oh yeah, that's
About
great. That's a
Jenny?
great thing.
Yeah.
Yeah, sure, why not?
I got to take this moment to announce, and hopefully she's watching. My daughter Jenna got into medical school today. So I am extraordinarily proud of you, Jen. Lifetime dream come true. I'm very proud of all three of my children. They're amazing kids. And I'm super proud of Jenna. And I am incredibly indebted to my amazing wife who raised three amazing kids for making this happen. It is a huge dream come true for me. And I am also hugely indebted to my mom and my aunt who literally tirelessly spend all day, every day, saying prayers for me and my children and our family. So huge, huge, huge round of applause and congratulations to you, Jay. I love you. I'm so, so proud of you. And no, you can still not get a tattoo or another piercing.
Dr. VT. Yeah, what are the pros and cons of taking progesterone during pregnancy?
We did that.
Good. Can you dive into what's the difference between a normal and IVF pregnancy?
Well, we just kind of went through a bunch of that, right? So you're at higher risk for stillbirth, you're at higher risk for genetic problems, you're at higher risk for congenital abnormalities, you're at higher risk for preterm labor, you're at higher risk for hypertensive disorders, you should be induced earlier. So those are the differences, and you need more monitoring. Fetal echocardiogram should be offered, genetic testing should be offered, and you should be offered growth ultrasound. You don't need that stuff in a normal pregnancy.
Hi, Dr. VT. That's it. There's a hello, friendly hello.
Hello back. Yeah, those are nice sometimes. You know, it's kind of cool to just have someone say hi.
I don't mind getting hellos.
Hey, yeah.
To be honest. I'm good with it.
Yeah, I'm getting some congratulations. I think the lady that had the spotting at 19 days said she did a pregnancy test and it was negative. I'm assuming it was her. Yeah, so then you need your hormones checked. I'd repeat the pregnancy test, and then it's hard to know what's wrong.
If you have endo, can just excision surgery alone increase your chances of conceiving naturally?
If you've had endo, can what?
Excision?
Excision surgery? Yeah, absolutely.
That's what I would actually do. Like if I was...
You yourself?
Yeah. It's
a 26% increase in success, which was roughly double the normal rate. So it's actually doubling your rate of success. Yeah. Nicole, you're welcome. I actually got that question right. I was right. Yeah.
I did a biopsy recently and results came back as irregular endometrial.
No, read that one.
Oh, okay.
Yeah.
Hi, Dr. VT. I found out I have endometritis and hysteroscopy was performed.
Okay.
Was put on antibiotics for 2 weeks.
Okay.
Should I repeat the test or do Fertility instead?
Do Fertility instead. Here's the problem. You got a diagnosis of endometritis. You did not get a diagnosis of which bacteria is causing your endometritis. So let's just hypothetically say that the bacteria you have is ureaplasma. And we treat you with Keflex and Flagyl, which would be common for endometritis, in order to kill off all the bacteria that are there. What did we just do? We killed off almost all the bacteria that were there, including all your good bacteria, many of the bad bacteria, and none of the ureaplasma. So you've got this soup, and in the soup is a whole bunch of different populations of bacteria. And I just went in and I took out a ton of the bacteria and left lots of broth for the bad bacteria. What are the bad bacteria going to do? They're going to grow like crazy. So I just took your problem and I made it worse. That's why biopsies are idiotic. They don't make any sense. There's no point in doing a biopsy because we don't know what we're treating. You can't just randomly treat people for endometrial endometritis or microbial infections because you don't know which one you're treating. It's like saying, I've got pneumonia. My pneumonia is related to, I don't know, some type of, I don't know what bacteria causes pneumonia these days, right? But you've got some kind of pneumonia bacteria, but the antibiotic you're taking is for like a bladder infection. It's not going to work. It's the wrong thing. So, it's just not the right thing to take. You got to take a focused bacteria. I got this late. It's tiny, but it'll help. How's that? Of minimal value.
Oh, yeah, 1 second. Just a little bit. That plug back there is not a horrible idea.
I know. We need to get that for you. Yeah, I'll get that for you.
Soraya has the most unique comments. She says that if you eat a lot of snails from Morocco with lots of spices, you will get pregnant.
Wow. I'm flipping through Instagram lately, and this thing keeps popping up. It's so funny. It's some fertility nutrition thing where they claim that we, the doctors, have it all wrong. and that you can improve your fertility chances by 50%
This is good.
completely naturally by paying attention to your gut microbiome. And I'm like, oh, for the love of God. Like, I'm a believer in that stuff. There's no question that the gut microbiome, all the microbiomes, we're just talking about microbiome. This stuff's all important, right? But are you going to get a 50% increase? She's the lady that's talking about it. She's like, you will get 10 times the benefit, 10 times the benefit by adjusting this than you would by like looking at your hormones. And like, are these people on crack? Like, where do they come up with these numbers from? It's ridiculous.
It's big business.
It's like the doctor that said that there's no difference between mature and immature eggs.
Yeah, I like that one. They're the same. Just imagine.
Oh my God. Oh my God. You know, I didn't get a chance to tell you. I was talking to a patient from Idaho yesterday, okay?
Okay.
Non-specific enough that I won't get in any trouble. And she told me that a very, very famous, well-known fertility specialist, who of course shall remain nameless, told her that her 10 previous miscarriages were caused because she ate fruits and vegetables. And this particular fertility specialist believes that people should only eat meat and carnivore diet.
Oh, really?
And only eat one time a day. And he literally told her, according to her, that the reason she was having 10 miscarriages was because she had fruits and vegetables.
Wow.
Okay, like call me an idiot, right? But let's look at a nice country like India, world's second largest population, predominantly vegetarian.
Yeah.
I'm thinking they're eating a lot of fruits and vegetables.
A lot of fruit and
A
vegetables.
lot of fruit.
A lot of fruit and vegetables.
They got the second highest population in the world. I'm thinking that's not really the reason they've got 10 miscarriages.
That's hilarious.
What an idiot.
You know, I wish that I would diagnose some of these questions.
Like, how do you even, how do you bring yourself as a physician, as a doctor, a trained?
That's a real doctor in Idaho.
No, he's not in Idaho.
Oh, he's somewhere else.
He's somewhere else.
Patients from Idaho.
Yeah, patients from Idaho.
Oh, amazing.
How do you bring yourself as a trained, licensed, tested fertility specialist to even tell someone something so nonsensical? Like,
that's why I don't trust doctors.
you can't just make stuff up and shovel it into people. Oh, my daughter's calling me.
Oh,
Jenna,
she must have died.
honey, hang up because I can't talk to you. You're interrupting with.
Should I decline the call?
Just decline the call. Yeah.
There you go. Okay.
Why is it so hard to get back in to see me? I need to come see you ASAP. Well, we didn't pause you, by the way. It was my daughter trying to call. It shouldn't be hard to come and see me unless you're trying to get in to see me for gynecology, which I pretty much don't do anymore. But if you're desperate to come in, we do have a nurse practitioner who can see you first, and that she'll bring it to my attention if I am able to deal with it. But if it's for fertility, let us know.
See that T, you paused us.
I know, yeah, it's all your fault.
They're ready to slaughter.
T is innocent. It was my daughter trying to call because we use my telephone to get on TikTok. I wonder if we could.
I got another phone coming. Just don't worry.
That's probably what we should do,
Yeah, I got
right?
another phone coming.
Yeah. All right.
Do you eat deli meat? I stopped after finding out it's a group 1 carcinogen.
Rare. I had a sub today that the drug rep brought. It had deli meat in it.
He sabotaged you.
Yeah, he sabotaged me. It was probably the first time in months. I'll have it maybe once every, I don't know, 6 months or something. Probably even less than that.
The next time he brings in Firehouse subs,
Yeah.
get the beef brisket.
Okay.
Because I feel like it's come in here a couple of times with Firehouse subs. So get the brisket. It's not processed.
I only had it once before. The girls were like, "Oh, you gotta have a Firehouse sub."
Yeah, there's a lot of
I
hype.
was
for
like,
that
okay,
one.
I'll have a Firehouse sub. I tried it.
Get the brisket.
The brisket.
Yeah.
All right.
Mental note.
Mental.
Relationship between TSH and the ability to get pregnant.
Very high TSH will impede your ability to get pregnant. Very low TSH will impede your ability to get pregnant. Normal TSH is fine for getting pregnant, but for neurodevelopmental outcomes, you want it above 0.3 and less than 2.5.
What are the chances of endo coming back after 3 laparoscopic surgeries?
Soraya is off the rails, right?
Yeah. You know
I
what?
don't even know what that means.
There's a whole conversation, and I always think it's the comments. I scroll down, I scroll back up, I scroll down, and scroll back up.
Yeah, I'm lost. What was the question again?
Oh, I gotta scroll back again now. What are the chances of endo coming back after 3 laparoscopic surgeries?
Oh God, why'd you have 3? 100% if it's severe enough. Yeah, like a lot is very, very high. You can never actually fully get rid of all the endo because it's microscopic, and so sometimes we don't see it. The studies say it's a 30% recurrence rate, but it depends on the severity. You got stage 4 endo, you're not getting rid of it. You can't. It's impossible to completely get rid of endo if it's really bad. If you got mild endo, like stage 1 endo, sometimes you can get rid of it and it never comes back. So it depends on how bad the endo is. And I guess it would depend on what caused your endo, although we don't know that answer fully. Today's show flew by.
Oh yeah, and it's still flying. How can we get in contact with the genetic counselor with your clinic? We had a successful pregnancy that resulted in triplets. We have 1 embryo left.
Whew.
That is a low level mosaic.
Yep, just contact us and we'll let you know.
I'm so excited about this research. Thank you for speaking up.
Bro.
Hello. Thank you for hosting these Fact or Fiction lives. I'm looking for recommendations on the next step.
Okay.
In terms of 1 chemical and 3 failed FETs, RIF, ERA showed no issues. Embryos are good quality.
Contact us. You need a consult. We'll walk you through what to do. I need to know your whole history. This is probably, I don't know if it's because of the show or because of the growth in our practice or whatever, but this is pretty much what I started doing now. I'm basically the go-to person for people that have failed in other centers, and they're coming to us saying, how do we succeed? And thankfully it's working, but that's a lot of what I'm doing now.
I can help offload some of that.
You can offload, that would be good. Yeah.
Yeah.
I need to hire other doctors. I think I hired another doctor.
Oh, really?
Yeah.
That's
yeah.
exciting as well.
This individual will be signing probably tomorrow.
Oh, really?
Yeah. Well, she wants to send it to her lawyer, but we've already agreed on everything. So yeah, it'll be quick. I'm excited. You met that person.
Oh, I met her?
Yeah.
Okay, then I know.
Yeah.
Cool.
Yeah.
Do you have recommended OBs?
Oh God, I'm not getting myself in that
Yeah,
trouble. Depends on where they are. Here in town, sure. I have recommended OBs. Come and talk to me and I'll tell you who they are. That is not something I'm broadcasting. We all have our favorites. But I will say this, I trust all of my colleagues. I am happy to leave any of my patients in the care of any of my colleagues. All of my colleagues are wonderfully well trained. They're good people. They're honest, and none of my colleagues will do something to better serve themselves over the patients ever. So we are a great group in Windsor. It's part of the reason I stayed.